I'll go back once a year. If I get off my medications, I have to go back to the hospital and get reestablished on my medications.
I said I'm not ready to get out on my own because at that point I wasn't medically stable.
So typically, we see people on average that have gone to the hospital in the last 90 days 7 times. Our requirement is about 3 to 6 times, and on average we're seeing it about 7 times. We have people that have gone 30 plus times in the last 2 weeks. So we really are targeting the most vulnerable, the people that are using the most highest cost resources in our in our local area, which are the hospitals, the ambulances, a lot of police contact, and they just never get connected to that outpatient care.
We were funded to do some unique things in Missouri to help reach out to individuals with behavioral health disorders. One of those was to help look at the emergency rooms. Emergency rooms were being inundated with individuals with behavioral health disorders. Those could be people with severe mental illness, those could be people with addictions, but it was mostly people that didn't really belong there. That was not the place to get the best care.
Many times people in behavioral health distress are taken to the emergency room by family members, friends, law enforcement, where they're stabilized and released without the needed follow-up care. This program is designed to identify those individuals and get them connected to a community mental health center where they learn coping skills and how to manage their symptoms and what they should do in the future if they're in behavioral distress rather than go to the emergency room.
Because there's a lot of people like me that have like mental issues, and there's a lot of backups at the ER. They need to be addressed, and like the people in mental conditions are treated a lot different than the other people. If you go into the emergency room, they automatically think that you're on drugs, and they automatically label you that you're high. And in like in my case, I wasn't. And so every time I go, oh, that's from meth use, or that's from coke use, or that's from this and that, and I don't use any drugs.
Well, generally emergency rooms don't have psychiatric professionals or behavioral health professionals on staff. They're not equipped to deal quickly with folks who come in, let's say, dealing with symptoms of schizophrenia. They have to call down a psych consult. That may take a long time. Individuals who maybe have active symptoms are harder to manage and might be disturbing to other individuals in the emergency room. They don't have bleeding legs and arms, so they're going to have to wait a lot longer. You know, individuals who come in intoxicated, they're probably going to get turfed to a bed to sleep it off and not probably get an appropriate referral to a substance use treatment. Hospitals are designed primarily to treat medical emergencies.
So we have a lot of individuals that are struggling with just co-occurring issues. So they have issues from both mental health and substance abuse, physical health issues. A very high percentage of our referrals, at least in the Kansas City region, are homeless. So over 60%, or about 60%, are homeless. After 3 months of engaging with those individuals, we've seen a huge 70% and higher of not homeless after 3 months.
Well, what's really unique is that we have 7 programs operating across the state of Missouri. And although they have similar goals, they are very different in their operations. I think much of it has been understanding that in the rural areas there were fewer hospitals to begin with, and perhaps fewer health resources for larger geographic areas. And so individuals who perhaps were in crisis or didn't know where to go did reach out to their local law enforcement, and that was a different trend that we saw emerge. But the essential process is that the community mental health centers have done sort of a scan of their community to include substance use treatment disorder programs, developmental disability regional offices, food banks, churches, anyone that could offer temporary housing or basic resources, law enforcement. They worked with all of those to assess what does our community need in terms of folks who frequently visit our emergency rooms, and how can we best intervene. The emergency rooms basically are given access, immediate access, to individuals from the community mental health center who are able to respond very, very quickly to someone who perhaps does present at the emergency room, but the emergency room then doesn't have to continue with the whole triage and admission process, because there's going to be a handoff to someone who can appropriately intervene with that individual and get them hooked up with their services.
They asked how our case management was going. So we talked about our case management. And I have some of the best case managers to work with at Rediscover. With these guys, I can pick up the phone, call the crisis line, and they can contact whoever's on call for me, and they'll call me back or send somebody out.
So far, you know, they got me in the ER program, or they got me in Katy Trail, you know, where I get my teeth fixed, you know, my eyes, my nose, and everything get taken care of, you know. I got a lot of issues, you know what I'm saying. I'm one of their clients, you know, like they give me like time to be there, you know, and plus, you know, I'm seeing my Dr. Wilbur, you know, he got me on several types of different medications, you know, that's working good, you know, but so far, you know, long, I listen to him, obey him, do the right thing, take the medication, don't drink or smoke. I smoked my last cigarette on March the 5th at 5:15 that morning, ain't had none since. I quit smoking crack over a year. I quit drinking over a year, you know.
But it minimizes then their return trips to emergency rooms, and that's been a big outcome. Individuals who were repeatedly coming to the emergency room because they didn't know where else to go, we've seen repeated visits drop significantly. So once we intervened with them and continued serving them in some sort of capacity, they're not going back.
As evaluators of the program, we found significant decreases in prior ER visits and hospitalizations in a relatively short period of time. There's been a 60% decrease in both ER visits and hospitalizations in the prior 3 months. We also conduct focus groups with individuals who are receiving services, and they let us know that the coping skills that they have learned have had a positive impact on their quality of life. They feel they are less of a burden on their family and friends, and we hear comments like, "This program has saved my life."
What's the good news is, I think we're seeing a lot of the things that we did expect to see and hoped to see. I guess I just didn't expect to see as dramatic of a shift. We are seeing a decrease in ER utilization. We are seeing a decrease in the use of psychiatric hospital beds. I didn't necessarily think that we would see such a large decrease in homelessness. You know, they're getting them connected with housing. I didn't necessarily think we would see a significant decrease in unemployment, but we are. As a result of being connected or coming into contact with this initiative, folks are getting housed. They're, you know, because there's a lot of homeless that come through this program. They're getting housed, they're finding employment, their arrest rate is down, and certainly more are plugged into our treatment programs, which we're glad about because many of them were out there not knowing who could help them. So I think, again, it's doing the things we thought it would do, but it's doing more. We're getting them to the right place quicker, and that's better for everyone. Right place, quicker, better care. So that's where we win in terms of quality services, quicker access, and it's much more cost effective for the state of Missouri.
It's giving me more time with my caseworker. It's giving me transportation. It's giving me sort of like somebody to lean on, like that's not in my family, and it's kind of taking the burden off of my friends. It's helped me be more independent and to come to the table every time I have a meeting with my social worker or my case manager. I have to have things that we're gonna do for the day. It makes me more responsible. And then taking my medication, I noticed that I've been having she taught me how to set an alarm on my phone for taking my medication, and I'm able to take my medication every single day, and so I don't have emergency room. So I have emergency room time.